Hello everyone. My name's Pardeep, and I'm the Clinical Evaluation Officer here at Blackwood Analysis, and I'll be moderating today's session. Thank you very much for joining us for this webinar, where we'll be exploring the role of AI in the sphere of neurology and neuroradiology. I am delighted and grateful to be joined today by a panel of experts from our platform partners, who will be delving into the nuances of challenges and problems faced today in the neurology space. We'll be covering a range of topics from different use cases, including stroke, neurodegenerative diseases, and neuro-oncology, discussing the challenges but also the opportunities that AI can bring in this field. So, to get things going, let's start to talk about stroke, a condition that currently will affect 1 in 4 people within the UK. So if I pose this question to Dr. Harston from Brainomics, as a stroke consultant or attending physician, what are some of the biggest challenges you see around managing stroke patients in the UK?
Just by way of introduction, as discussed, my name is George Harston. I'm Chief Medical and Innovation Officer at Brainomics, also a stroke physician in Oxford. I think the biggest challenge is about identifying the right patients, getting the right treatment, and doing it as efficiently as possible. As we all hear time and time again, time is brain with stroke. So not only do you need to identify the patients, but you need to do it in a timely manner. And I think this is one of the great opportunities in stroke for AI to add value to the patient pathway, is to help both to identify the right patients to treat, but also to ensure it's done in an efficient manner. And what we see then, the impact of implementing technology that can do that is not only more patients treated, but also better patient outcomes as well. To do that, we have to think about the context in which patients present to hospitals. And of course, most patients don't go to a specialist academic centre. In fact, about 80% of patients go to what's called a primary stroke centre in the UK, or sometimes called a spoke hospital. And these centres typically will have more generalist expertise and lack both the imaging technology, so advanced imaging in the emergency department, but also the specialist expertise to provide reliable and consistent interpretation 24/7. And so that's really where we see a big opportunity for our technologies to add value to that patient pathway, to address that unmet need of the generalist physicians and the less specialist equipment in that setting.
Perfect. Thank you very much. Following up from that, can you tell us about the recent results of your prospective study in the NHS and what this may mean for AI improving stroke-related patient outcomes?
Yeah, certainly. So this was a 3-year prospective evaluation of the impact of our technology across 26 hospitals in the NHS. It was an NHS AI award funded project, and it was independently evaluated. The impact was independently evaluated by the academic health science network, as they were then, now the health innovation networks. And what we looked is using the national stroke audit infrastructure, we looked at the impact of the implementation of the technology on the numbers of patients treated and how efficiently they were treated. What we saw was a sort of additional 50% increase in the number of patients getting access to mechanical thrombectomy, so minimally invasive surgical intervention for stroke. These are the biggest strokes, and a very effective treatment. And we saw an over 50% increase compared to the national average in the access to thrombectomy in those patients. We also saw a reduction in what's called the door-in, door-out time. So the time a patient takes for a patient to arrive at a hospital and then leave a hospital to get definitive treatment if they're a non-specialist centre. And we saw that was nearly an hour reduction, which is a big impact on patients, because every minute that goes by, you lose 2 million neurons. And what was important about this study is that we didn't just do it in specialist centres. So we did it in representative stroke networks, about 5 different networks in England, which consist of a specialist centre and a hub, and then generalist centres and bespoke hospitals that refer in. And we saw this consistent impact. What was unique about this study was the fact that it included every single patient with a final diagnosis of stroke presented to these hospitals. So nobody was missed. It wasn't a sort of very selective trial. It was all comers, and yet we still saw an impact. And also it was all types of hospital as well. So most of the hospitals were non-specialist centres. And that evidence, I think, is been really important for us to show that the results that we've seen in other settings. So, for example, in mainland Europe, where we've seen similar sort of impacts at a single hospital level, are generalizable across systems of care. Um, I think you know, it tells its own tale in terms of the numbers of patients involved. So we had individual patient data from over 80,000 patients with a diagnosis of stroke. And in fact, we say it was in 26 hospitals, but the comparator group was the remainder of the hospitals in the NHS. So actually, it was every single stroke patient in the UK, in England rather, as part of this analysis. And what we know is that if the same impact had been seen across the whole of the NHS in England at the time, there would have been hundreds more patients in England who would have been treated with thrombectomy. And we know that this is not only incredibly important for these patients, but also has a very positive health economic impact on the wider society, because you reduce long-term disability and dependency, and therefore it is a win-win. Improving the access to this treatment.
It sounds amazing. And just I'm going to carry on from that with stroke and just move on slightly. So I'm going to pose this question to Tamagna from Cure. What's your view at Cure on how stroke care coordination can bring relevant team members together faster?
Nice being here. I'm the lead radiologist and director of products at Cure. So yeah, just to answer your question, I think one of the biggest learnings that we have had when we had the AI product actually go out to the market and give it to clinicians is that AI is only like a small portion of the whole value add to the care pathway, right? And majority of it does come from care coordination. And I think care coordination, or the benefits of care coordination, just boils down to three things, right? Which is timely communication, having streamlined workflows in place which can be initiated, and also like helping clinicians make faster decisions. So I think when it comes to like timely communication, I think like the benefits come from just passing on the information very quickly, right? It could be notifications if it's a system, if it's a health system where there is an emergency services provider, right, or where there is a first line of contact from a first line care physician. I think just having that notification being sent to a specialist center where there is a neurophysician to look into it and actually help with the interpretation. I think that saves a lot of time. Or just having like a common platform where all the different stakeholders of the stroke unit actually come and interact, rather than having to pick up the phone and call each one, separately, or passing on that information. That, these simple things actually add up and does lead to drastic reduction in the overall time saving. The second thing is just having using technology to actually have streamlined workflows, right? So many parts of the world, many health systems will not have a 24/7 radiologist present to actually interpret your CT or an MRI. They will not have a neurologist actually guide the first line physician or the ER doctor, right, on whether or not it is stroke and whether it is thrombolysis, whether it's, mechanical thrombectomy is required. So that is where, supporting care coordination and supporting telestroke model, where we can pass on this information in a secured manner, get specialists to actually guide treatment on the ground. That really helps. And I think the last part is where, AI really shines, which is just AI for using AI for image interpretation so that we can have early diagnosis, and then setting it out or supporting, the clinical decisions that actually stem from it. So one of the things that I had an opportunity of working on was actually the difficult process of getting a first line physician to decide whether or not a patient benefits from doing a transfer for mechanical thrombectomy, and can we try to like simplify it, right? And today we have algorithms which can take in very basic information regarding the patient, and just looking at the NCCT and actually seeing what is the probability of that patient actually benefiting from advanced stroke care. And these kind of things actually they just reduce the time lag or the friction. And as George said, time is brain. And that's how it helps.
Perfect. I mean, staying around stroke care, previously AI for stroke care coordination was reimbursed in the US under NTAP. But so how do you see reimbursement or return on investment being realized for these type of applications going forward?
Yeah, I think NTAP was very beneficial in actually overcoming that initial barrier to adoption, right? For AI when people needed a lot more convincing. But I think the market's maturing, and we have a much clearer understanding of where that ROI kind of stems from, and that's going to be from the cost savings both for the provider as well as the payer, right? So we know for a fact that care coordination, especially AI powered care coordination, does lead to decrease in door to needle times, door in door out times, or door to puncture times. And we also have good evidence to say that if you have lower numbers on these important stroke matrices, that leads to decrease in the duration of ICU stay, that leads to decrease in the duration of hospital stays, and decrease in complication rates, right? So all of that can actually result in a lot of cost saving, both for the provider as well as the payer. Additionally, when you're looking at quality metrics, like those are goals for the hospital to achieve, and long-term disability, right? If we can act the burden of stroke actually stems from patients requiring long-term nursing care or assisted living, right? Even beyond beyond the acute phase. And that's something that we can drastically reduce. So these are things that will lead to cost savings, both at a health systems level, at the hospital level, as well as be it an insurance provider or any payer. And yeah, that is what will generate the returns for investment into AI.
No, yeah, that's a really interesting view, and yeah, I would agree with those sentiments. Taking a slight sidestep, but kind of staying in that region, perfusion has been used clinically for many years, but sometimes its utility has been debated. Kim, I'm going to pose this to you. What is Serica Medical's take? Are we doing perfusion optimally, and are we getting maximum quality and value?
Thank you very much, and thank you for the opportunity to join you guys. Very happy to be here. So I think this is a very important question, and one that goes very much in dovetails with what we have heard so far, because we have heard so far about sort of the care coordination. What we are concerned with is the input that you might give to AI algorithms or to the clinical decision making. And so in acute stroke, for instance, which is an occlusion of a major vessel, of course, you have a disruption of the blood flow, and that impacts tissue and tissue oxygenation downstream. And so what we are kind of wrestling with in Circare Medical is a reinvention of perfusion. We call it perfusion 2.0 because basically for around 20 years, there has been very little progress and advancement in that field. And what we're seeing is that basically, so once information has been transported, as we're discussing right now, and a clinical decision needs to be made, the sort of the traditional model for that has been something called the perfusion-diffusion mismatch with MRI. And that basically means that you're looking at identifying regions of tissue that are irreversibly damaged. And if that area is not too large, then there's an indication for treatment. Now, what we are seeing, and this has also been demonstrated in some of the major journals, is that many patients are actually not benefiting from treatment, even though the revascularization has been successful. And if you go back and think about, how we're actually defining these concepts, they were actually defined in PET imaging many, many years ago. So what we mean by irreversibly damaged tissue is actually tissue where metabolism has ceased. And so what we can do uniquely with Circare Medical is that we are not only looking at flow and flow phenomenon and blood volumes, but we can actually make images that are portraying oxygenation and metabolism. And so we're coming out with publications now, some of them are already out, that show that when some of our markers are high, that is actually a marker of DWI reversibility. And that's something that I think has not really been seen in the clinic before. And similarly, we also have publications and studies now coming out that show that in many cases, the lesion, the initial lesion might actually be growing. And we have markers that are basically indicative of which patients will experience an increase in the irreversibly damaged tissue. So basically something that potentially has an impact on the triading of stroke patients. I think all this dovetails really nicely into the care coordination that we have talked about so far.
I mean, following on from that, is there a broader potential for perfusion than we realize today, including any, implications for neurology and other subspecialists in the hospital?
Yeah, so I think we can go much further than this. And actually, what we have discovered is we believe a pretty fundamental disease mechanism and sort of a mechanism that's a driver behind many diseases. And just to give you one more example, we're looking at a lot of oncology. We know that tumors are growing when they lack oxygen. So when we have a platform technology that can essentially image in the clinic the availability of oxygen, there's a potential for this technology. And we have a lot of publications coming out now and a lot of customers who are using the software to, for instance, predict where metastases are going to form. And we have examples of patients coming into the clinic, having a diagnosis, getting a resection, getting radiation therapy, and then we can actually predict a location of relapse 1.5 years later than that. That is something we have also seen with neurodegenerative disease, not only in adults, but also in children. We have conducted studies that are published in Nature together, for instance, with Mass General, showing that in a pediatric disease called adrenoleukodystrophy, which is a demyelinating disease that can potentially, worst case, kill the patient, we can actually predict the onset and the course of the disease. It indicates up to around half a year earlier. And we have also been instrumental in showing that gene therapy is important in saving these children. So I think the potential here is much wider than stroke, and so it goes for oncology and a range of other diseases as well. So there's a ton of unlocked possibility in perfusion imaging.
Perfect. Thanks very much, Kim. And this dovetails nicely for me, moving all on from stroke for the moment. And let's just go talk now about neurodegenerative diseases. So I'm going to pose this question to Olivier. So how can AI support the diagnosis and management of neurodegenerative diseases? What's Kynapse's views on this?
Okay, thank you, Jay, and hi everyone. It's really a pleasure to be with you today. So for neurodegenerative disease, AI is used in two ways. First, to support initial diagnosis and differential diagnosis by providing precise assessment of regions of interest involved in neurodegeneration, and by providing for patient comparison with a normative data set of healthy subjects, same age, same sex. And secondly, AI is supporting the longitudinal monitoring of clinical progression and drug efficacy by monitoring precisely changes over time between 2 exams, 3 exams, in order to support the monitoring over time of the disease and the drug efficacy. And at Kynapse, so our initial focus has been clinical research. So we've been rolling out our platform for clinical trials to assess the efficacy of new therapies in Alzheimer's, Parkinson's, epilepsy, and others. And all the algorithms we are providing through the Blackford platform have been rolled out and validated as part of clinical trials.
Perfect. And I just want to explore this further. So how does this benefit kind of the referring neurologist and the patient?
So the benefit for neurologists and patients is a more accurate initial diagnosis, and more specifically differential diagnosis, which is in Alzheimer's, Parkinson's, for instance, the identification of disease subtypes, which is a challenge in clinical routine. And secondly, precise monitoring and robust standardized monitoring of clinical progression independently of the equipment that have been used to acquire the images. And as you know, so inter and intra-reader variability, it's a problem in imaging. So by applying AI, there is a benefit for clinicians to have much more standardized and robust analysis independently on where the patient went to get his MRI performed. And in the context, especially for Alzheimer's disease, of now new drugs coming to the market, there's been two new therapies approved in the US in the last few months. It's making all of this even more important.
That's great, and very good. And mentioning that, it's exciting times with the recent approval of lecanemab and donanemab for the slowing of progression and early Alzheimer's. I'm just going to pose this to Jan from Icometrics. Can you share with us how AI can support like these new therapies and generally new therapies in general?
Yeah, thank you, Pradeep. And as Dirk here, the CTO of Icometrics, and exactly as Olivier mentioned, these two therapies have now been approved in the United States. And the very positive aspect is that the clinical trials have demonstrated that the cognitive decline is reduced when people with mild Alzheimer's disease are put on those therapies. Unfortunately, these therapies have also side effects, and more specifically, side effects for which imaging is super important. And that's, I think, where AI and imaging is playing a very important role. There is a side effect that is called ARIA, amyloid-related imaging abnormalities, which are bleedings and edema that can be seen on the MRI scan. And AI is definitely of help there to increase the capabilities of the radiologist in detecting and quantifying it. Because people on those therapies need to be monitored very, very closely and can be put off therapy in case there is severe ARIA, so severe bleeds or severe edema. And AI will help there. For example, we have developed a tool called IcoBrain ARIA that is allowing to do the assessment. And we show that the sensitivity of the radiologist is significantly increased with that. And therefore reducing also the risk that patients have that potentially deadly side effect that accumulates and leads to potentially fatality. So I think AI has an important role there, absolutely. The other small point I want to add here is that before patients start on therapy, it is also important to look at risk factors. And MRI, again, plays a very important role there. The number of microbleeds before the patient starts on therapy, the presence of other risk factors on MRI need to be assessed. And also there, AI will help, like our IcoBrain DM solution, to identify those such that neurologists or geriatricians can make more informed decisions to put people on those therapies.
Yeah, those are completely agree, very important points. Just taking a slight sidestep, but can you tell us about kind of new category 3 CPT codes for brain volumetrics and how US healthcare providers can take advantage of these?
Yeah, absolutely. I think this is a game changer. So Icometrics has had the chance to apply for this CPT3 code last year, and we successfully defended that based on the evidence that we have demonstrated in several disease domains. So that is an important one here already. So for multiple sclerosis, Alzheimer's disease, Parkinson's disease, traumatic brain injury. And the essence of this code is to monitor patients over time. And it's sometimes referred to as the brain volumetrics code, but it actually requires also the assessment of lesions and lesion changes, which is essential in many of those disorders. This is, I think, a game changer because this CPT3 code has also received the status that it is a payable CPT3 code, making that indeed US providers are being reimbursed today for the use of IcoBrain in clinical practice. And this is, I think, a very important step to make IcoBrain and other tools standard of care to really help patients with such neurological conditions.
Cool, thank you. I mean, monitoring and tracking diseases such as MS on MRI can be time consuming. You've brought it up. I'm going to pose this to Shannon at Pixel. Can you explain how AI can help make this process easier and what benefits it would bring?
Sure, Pardeep, thanks for the introduction and the opportunity to speak here with my fellow panelists and friends around the table. So I'm CEO and of Pixel with a background in AI and engineering. Just for context, for additional context, I think it's probably interesting to highlight the role of MRI in the MS patient care pathway. MS being a chronic inflammatory disease of the central nervous system, a demyelinating disease. This damage to the nerve fibers can be viewed on MRI images, and MRI then is very crucial to understand the presence of the disease, the evolution of disease over time, and eventually the prognosis of the disease. I suppose the good news is that there are over 20 disease modifying therapies on the market, and so the neurologist is armed, I suppose, with these therapies and has to make the important choice as to adapting which therapy to use for which patient and at which time, and that's really where the role of imaging comes in, and the time-consuming nature of the MRI reading is I suppose highlighted by, or can be justified by, looking at the MRI exams in question. They are one of the most complex radiology readings. We've got MRI images of the brain with increasingly high resolution. The need for the radiologist to assess multiple visits to assess the activity of the disease and to track the lesion's evolution in time. And then we also then have the real world context where these imaging exams can come from multiple centers, and so can have inherent variability in their quality and the acquisition parameters. Coupled with the high lesion load and the fact that lesions can be subtle, very subtle, this leads to radiology read that is actually quite challenging, and it's documented in the literature as to the dependence that this reading can have based on the experience of the radiologist, and also the different complexity of the MS case.
Thanks. And just taking this forward, how do you think this would also help the referring neurologist, the clinician?
So I suppose the clinician and the radiologist often work hand in hand, or their work is driven by the same goal to help the choice of treatment. I suppose AI can help the radiologist in a number of different ways, by reducing reading times, by increasing providing an enhanced detection rate of the lesions, and providing peace of mind for the radiologist. I suppose the neurologists themselves, given that they are sitting down with the patient and have to make the best choice as to the treatment for the patient, really the ultimate goal is how can the neurologist avoid or maybe delay the onset of a relapse or the progression of disability, or even the evolution towards a progressive form of the disease. And so with that in mind, really the enhanced detection rate is the benefit that is most pertinent for their work. Really enhancing the detection rate essentially means that the disease activity is detected as early as possible. And so detecting when the neurologist sits down in front of a patient at the early stages of the disease, this is when it's really crucial to have all the relevant information. This is when it counts. A choice of treatment at that stage can have a profound impact on the eventual prognosis and really ultimately the life and the quality of life of the patient. Understanding the disease activity will allow the neurologist to really make the most relevant choice when it comes to the treatment and ensure that the right treatment is given to the right patient at the right time.
Perfect. That's really comprehensive. Okay, so we're going to move on slightly and go to a relatively up-and-coming area, which is use of AI in neuro-oncology. I'm going to pose this question to Michael, Imaging Biometrics. What are some of the challenges you found radiologists face when interpreting neuro-oncology cases, and what solutions are available to help them?
Yeah, well, thank you for having me. It's a pleasure to be with you all. I'm Mike Schmein. I'm the co-founder and CEO of Imaging Biometrics. And I think there's quite a few challenges facing radiologists in their interpretation of neuro-oncology cases. Of course, the heavy workload, they're being inundated with many, many images and trying to keep up and so forth. But I think the main underlying challenge among treatment teams in general is identifying whether the enhancing region is tumor or if it's an effect due to treatment. So I think, the conventional imaging that is being used now, the pre and post contrast T1, of course, which is applied to RECIST, Raynaud-McDonald criteria, often fails to distinguish tumor growth from pseudoprogression or post-treatment radiation effect, which of course can mimic tumor on contrast-enhanced MRI. So the ability to distinguish these types of tissues is necessary, of course, to determine if a patient should continue with their current treatment course, return to surgery, or if they're eligible to participate in a clinical trial, et cetera. So what we've done here at Imaging Biometrics is we created an automated platform that can quantitatively assess and distinguish within the enhancing region what is tumor and what is non-tumor tissue, and we can track that over time. So it's a two-pronged approach that uses our technology called Delta T1 maps, which is a quantitative difference map. It's built in, it's automated, so it can detect subtle regions of contrast enhancements easy, and also subtract out confounding factors such as post-surgical blood products. So what you're left with is a true region of enhancing tumor. And then using our perfusion approach with IB Neuro, we can then generate quantitative CBV values, which have been correlated to distinguish between tumor and non-tumor tissue by a couple, multiple sites now. And so within that, we can create these maps called fractional tumor burden maps. And again, these maps can be class maps that can distinguish tumor from non-tumor tissue, and they can be tracked over time longitudinally because they are quantitative. So that is one approach that we are using to help the radiologist and the whole treatment team, answer that question, is whether the enhancing region is tumor or if it's an effect due to treatment.
Great. I mean, I know that's a daily challenge for many radiologists when they're reading those scans. You brought up clinical trials. I'm just going to pick up on that. So how could this application be used specifically to support clinical trials?
Actually, it's a great question because early in our development, we participated in some early clinical trials with Akron, which allowed us to, of course, beat up our software from acquiring data from different sites and different scanner platforms and so forth. So we've been involved with clinical trials here in the US since the get-go. In fact, I think our perfusion approach is the only DSC platform used in multi-center clinical trials. But again, it's the ability to more accurately assess response in treatment therapies, whether it's a pharmaceutical type of clinical trial or just an imaging trial. The ability to have a common platform that's kind of standardized across sites that can harmonize all the data and make it consistent for a direct comparison is really useful approach with our platform. So I think it's a ripe area. It's a area that we've been participating in for many years, but there's certainly more clinical trials to be done, and especially with pharmaceutical and drug development companies, a number of subjects you need to prove efficacy could be enhanced with advanced imaging or AI solutions, definitely.
Perfect, thank you. Just moving on a bit now to kind of more the operational benefits of AI. Martin, I'm going to pose this to you. How can AI triage of acute neurological pathology such as brain bleeds or blockages of large vessels support the radiologic workflow and drive efficiency? What's the view at Avicenna?
Thank you, Pradeep, and and of course the Blackboard team for inviting us to this webinar. My name is Martijn Jonkers. I'm the VP Sales of and Marketing of Avicenna AI for Europe, Middle East, and Africa. Thanks for this question. Actually, a good question also, and I'm very happy to share with you some examples actually on how Avicenna's AI tools support radiologists and drive efficiency and I will also share some real life example, because at the end, the real life examples that resonates the best. Again, streamlined triage and prioritization of urgent cases. I think that's very important. So our intracranial hemorrhage solution, for example, detects and enables actually the quick identification of hemorrhages on non-contrast CT scans, which is especially critically in head trauma and hemorrhagic stroke cases. By recognizing the suspected hemorrhages early, the AI solution pushes these cases to the top of the radiology work list and makes sure and ensuring that potentially life-threatening conditions are addressed without any delay. And this prioritization helps radiologists actually focus on the high priority cases first and reducing the overall turnaround time. And as an example, I think, and one of the case studies that has been shared with me from an actual customer recently is it relates to the intracranial hemorrhage, that a 39-year old man actually is admitted after being found unconscious with head injuries at 3 a.m. in the morning. At 3:15, an immediate non-contrast CT of the head is performed to assess the potential brain injuries. And overnight, the report has been created and notes a right fracture, but missing some subtle signs of hemorrhages. And that actually at 7 a.m. in the morning, the attending radiologist identified actually an hemorrhage that was missed earlier. That means that in that time slot, 4 hours have been missed actually. So that's an example of how AI have changed this situation if the AI was available at that moment. Because remember, I get back to the 3:15 in the morning when the CT scan was performed. 1 minute later, potentially the automatic detection has been completed, showing a potential hemorrhage in the image, and prioritize the work list for the overnight radiologist to re-examine the images with the findings. So this is an excellent example, a real world example of how the impact and how it can be supportive to the radiologist in time. And it's similar for the detection of large vessel occlusions, patient outcomes. Any delay in a diagnosis can impact the patient outcomes actually significantly. And the AI capacity to detect the LVO quickly and again prioritize these cases means that radiologists can act more promptly, enhancing the chances of better recovery and reducing the long-term disability of the patients. So that's quite some interesting stuff that's been showing to us as some examples of how it can be supportive to radiologists.
Thanks very much for that, and I'm sure a lot of people listening to this will resonate with what the case study you've heard. Just building on that, in general, from your experience with customers, what are the reasons you've come across from healthcare providers for wanting to adopt such AI applications from the healthcare provider perspective?
Thanks again for this question, because it's of course very relevant, because that's why we're all in this webinar, right? So in the field of neurology and particularly in stroke care, AI solutions like those from Avicenna for the ICH detection and large vessel occlusion detection are actually transforming the way healthcare providers manage time sensitive and critical cases. from my experience, at least, working with healthcare providers, I've identified a couple of key reasons actually that they are actually eager to adopt the Avicenna's AI applications in their clinical setting. And I think it's obvious for you guys, but hopefully it's for the people watching the webinar. Time sensitivity and improved patient outcomes is definitely a number one for us. It's reducing the clinical delays. So in both ICH and LVO cases, timely intervention is paramount to preserving brain function and minimizing long-term disability. Streamlining workflows for radiologists, especially in busy settings or overnight settings. AI can triage imaging cases, automatically flagging those with suspected abnormalities. So this allows radiologists to focus their immediate attention on and their experience actually on high-risk patients and improving efficiency. So these are just two of them. We have a couple of more, so if interested, please reach out, because the motivation to adopt the AI applications like ICH and LVO, because these two, again, significantly enhance the patient outcomes, the improved diagnostic accuracy, streamline workflows, optimize resource usage, and position institutions actually at the forefront of medical innovation as we are in healthcare today.
Thank you very much. Yes, I think we can all resonate with that. And last but definitely not least, we have Reino here, Annelies. Thank you very much for waiting patiently. I'm just going to start. So the EU MDR have generally permits a broader and kind of more comprehensive set of application features to be used in AI applications. Can you share with us how this can benefit radiologists reading CT head images?
Sure. Pradeep, thank you for having me here in this webinar, and it's a great opportunity to share with all our colleagues here our view on AI. And to point your question, right, I'd like to go back actually to answer the question and understand what is the radiologist required when they receive a CT brain study non-contrast, right? What is the objective? Which is basically to detect all the relevant clinical findings or pathologies which are visible in the study, right? And flag acute findings quickly to initiate potential additional diagnostic tests and/or treatment, and write in the end a comprehensive report which includes all the relevant clinical findings. So answering the clinical question like just is there an infarct or a fracture is with just a simple yes or no question actually is not sufficient, right? And what about the incidental findings? What about differential diagnosis? For example, if there is an ICH, as Martijn already mentioned, right? What is the type? The radiologist needs to describe what type of ICH this is. Is it acute or perhaps chronic? And these are the typical questions that we see radiologists are facing when reporting a CT brain non-contrast study. And at Annelies, we aim to support the radiologists with this comprehensive AI solution, which can assist them in every single CT brain case that they are confronted with, regardless of the clinical question, regardless of the referrer. And a comprehensive AI model will be relevant for any patient at any time. And it will not only be beneficial to the radiologist in detecting of these findings as described earlier, but as Martijn also mentioned and others, triaging the more acute cases and prioritize that patient in the work list based on the outcome of the model is extremely important. And when a comprehensive AI model includes multiple acute artifacts or findings like an ICH or an infarct, it can prioritize those acute patients. And on top of this prioritization, we can support the radiologists with reporting, sharing those findings in their existing potentially structured reporting solutions to save time and further standardize their reports. So to summarize, comprehensive AI solutions can benefit radiologists by efficient triaging, clinical finding detection or decision support, but also reporting.
Perfect, thank you. We heard the views there from Martin. I just wrote at Annelies, what are your experiences in terms of healthcare providers wanting to adopt AI? Like, are there any reasons that you found? I'm sure you found similar reasons, but obviously everyone has differences. Are there any differences that you found in terms of the adoption of health by healthcare professionals and healthcare providers?
Yeah, I think the two main reasons for adopting any AI solution today is to improve overall accuracy or performance and or the efficiency, right? And CT brain non-contrast has no exception to this. And to basically start with the accuracy part, right? I think if you look at the root cause that triggers this question and this need for an improved accuracy is that very simple, right? Radiology departments are understaffed, are not having the staff available, or maybe a radiology department is having enough staff, but still missing the well-trained staff or subspecialized staff for neurology, for example. Or the staff is not always available, especially during night shifts. Very common use case that we see that people are investing in an AI solution to cover the night shifts, for example. Or when non-radiologists, such as an emergency physician or neurologists, would like to have an assistance in interpreting these cases at point of care. And we also see the need across a radiology department to improve let's say, the stability of the performance of the existing staff. I think everybody will recognize that we all are facing, after dinner or after lunch dips, right? And that will have an impact in our accuracy, in our performance. AI is always on, right? AI is always consistent and providing stable support for the radiologists to improve their performance and accuracy. And if we look into efficiency, we see the need. And we get many questions on this. And yes, we are able to improve efficiency improvements with the deployment of our AI solutions. But I want to say it requires time, right? AI is not a solution that you just implement. You train the staff on which buttons to press, or not even any buttons, right? Zero press, zero clicks, and the efficiency improvements are there. It's all about adoption, understanding the nuances of the AI results, and building trust into the AI model. And we think with our confidence bar, for example, that we provide with our findings, we can help understanding these nuances and build trust in the AI model. On top of that, triaging, as mentioned earlier, is a very important component of driving efficiency as well, especially for those most critical cases. And to be honest, the efficiency gains that we all are looking for are not only achieved by optimizing one or two or certain examinations. It's an optimization of the total workflow and workflow management across the department, across the hospital, where AI can play a large role. So these are the examples that we currently see.
Yeah, that's a really good insight, and I definitely agree. The use of AI as a tool and the education required for the adoption to see this true value is something that we need to be patient with, but will ultimately we hope bear fruition. Well, thank you very much for that answer, and thank you everyone for your contribution today. I'm sure you'll all agree that the range of topics we've touched on today and the debate we've had, that the challenges in the field are very much present, but so are the opportunities to solve them with the use of AI. So once again, I thank you all for your participation and the time you've taken out today. And we look forward to all your contributions in this field moving forward. So thank you very much.